lessons from the field, vaccinating our immigrant and migrant communities. And we're super excited to welcome all of you to our webinar, as well as our wonderful panelists that we have with us today. So essentially what we know during COVID is that it has not been easy, and not one step of the way from March 2020 until today, which is October 2021. We are hoping we'd be further along, but we are making progress. Nonetheless, we have wonderful frontline providers with us today who are going to talk about what they've been doing during COVID, what their challenges have been, and some of their strategies. We really encourage you to actively engage with us in the chat box. We love to hear from you and your ideas. And so each panelist will talk for a little bit, and then we'll open it up for a question or two. And then we're also going to share some resources with you. And at the end, we'll have time for some more questions and answers. To get us started, I'm going to introduce each of our panelists, and then we'll go ahead with our first panelist. So first is MCN's former board chair, Dr. Eva Galvez, and we're so excited that she's here with us. She's been here with us throughout COVID in various capacities. So here she is again talking about what she's done. She's a board certified family physician at the Virginia Garcia Memorial Health Center in Oregon. As the daughter of Mexican immigrants and agricultural workers, she has special interests in the health issues facing immigrant families and agricultural workers. Outside of her busy practice, she spends time providing education on health issues and the impact it has on the Latino community, raising awareness around health disparities. She is our immediate past chair at MCN. Our next panelist is going to be Carolyn Johnson, and Carolyn is the clinical director of Proteus Inc. That's an organization that provides advocacy, health, and support services to agricultural workers throughout the upper Midwest. She has served as a clinical director since 2019. And also, we're super excited to have Caroline here because she is our inaugural recipient of Migrant Clinicians Network's the Kugel West Health Justice Award, which we launched in 2020. And that recognizes a frontline clinician who's making an impact on the intersection of health and vulnerability within the migrant and mobile populations. We also have from my hometown, Salisbury, Maryland, or the Delmarva area, really, is Nadia Julian. She's a family nurse practitioner at the Tabitha Medical Care in Delaware. And I say my hometown, I'm in Salisbury, Maryland. All of us on the Delmarva Peninsula, we're from the same area, even though we're actually from different states sometimes. Nadia is the CEO and founder of Tabitha Medical Care. She is a family nurse practitioner and clinical nurse educator. She's passionate about the health equity and breaking down language barriers that make it difficult for immigrant populations to access adequate healthcare in a timely manner. And then I'm excited to have Sarita Wilkins with us. Sarita Wilkins is the communication strategist for the National Resource Center for Refugees, Immigrants, and Migrants, where she leads the communication efforts for the centers, as well as guides the creation and dissemination of health education materials. Before joining the team at NRC RIM, she spent more than a decade leading communications for K through 12 public schools. So I welcome to all of our panelists, and reading Sarita's introduction, I am reminded I wanted to say a great big thank you to the National Resource Center for Refugees, Immigrants, and Migrants, or NRC RIM. MCN is a core partner with that. And it is through that project that is supported by the Centers for Disease Control that we're bringing you this webinar today. So with all those introductions, again, feel free to put anything in the chat during this. Martha, I'm going to ask you to sort of get rid of all of us and on the screen, and we'll let Eva have the floor. Thank you so much.
Thank you, Amy, so much for that introduction. And I just wanted to welcome everybody that is here today. Thank you all for the great work that you're doing in the community, and to my co-panelists. I am going to be sharing my screen right now. Let's see if, can you guys see that now?
Yes.
Perfect, great. Well, just like Amy said, my name is Dr. Eva Galvez, and I'm a family physician. And I wanted just to show you where I'm located at, just so that you can kind of get a feel for where I'm at. So I am in Oregon, and I work for a federally qualified community health center, Virginia Garcia. And we are in the upper kind of north western part of Oregon, and we serve people in 2 counties, Washington and Yamhill counties. So kind of an area outside of Portland into more rural parts of Oregon. We have several primary care clinics, dental clinics, school-based health centers, a women's clinic, and an outreach clinic, or a mobile team, I should say. And really, I think what sets us apart from some of the other clinics in the area is that we really do serve a diverse patient population, but we really do have an emphasis on migrant and seasonal farm workers, as well as other people who have barriers to care. So many of the patients that we serve are Medicaid, are uninsured. They have many chronic health conditions. Most of them prefer to speak a language other than English, and the most common language that we speak is Spanish. But really, we have a relatively young population, and many of our patients are part of this essential workforce that we know. So lots of nursery workers, farm workers, with construction, care providers, people who are working in food factories. So relatively young population. And really, therefore, it's not surprising that we had a really disproportionate impact to our community when COVID hit. And so just to kind of give you an idea is, in Oregon, the positivity rate for COVID hovered around 5%. It has been around, at least throughout the pandemic, about 5%. But for our patients, if you were Latino and a patient at Virginia Garcia, our positivity rate was between 16 and 20%, and it continues to be that even as late as this month. And so if you're Latino and you are a Virginia Garcia patient, you're basically 4 times more likely to have COVID than other people. So really, really, not surprising. We were hit hard. And so, when I want to kind of just set the stage. So this is a very vulnerable community, really impacted by COVID. And so when we heard about the vaccine being developed, we really knew that we were going to have to take kind of this hands-on deck approach to really get the community vaccinated. What we knew was that many of our patients were going to have many barriers to getting vaccinated. So the same barriers that we saw to testing were going to be barriers for our patients. But we also knew that our patients want to work. They can't miss work. It's hard for them to work. So we knew that we wanted to have a vaccine rollout that would be convenient and accessible for our patients. And so what we did is, over the last year and a half, I kind of, in my brain, the way I think of the way our vaccine project has gone is I think about kind of 3 different areas. And the first thing is that we really had to completely modify our operations. So we kind of had to take our strategy, our usual strategic approach for being primary care clinicians and thinking about chronic illnesses, kind of had to be put to the back burner. And we really had this strategic plan that focused on priority to vaccinate not only our patients, but our community. And this really required not only the medical clinics to be on board, but it really required people from medical, dental, pharmacy, and admin to support this large scale effort. So just to kind of give you an idea, we had people from admin who during our vaccination days were in the clinic helping with people, helping people sign forms, helping people sign up for their second office, their follow-up visit. So we had dentists, we had pharmacists who were vaccinating. We had our referral coordinators that were helping people get through the line. So really we had everybody kind of in on this, what was really a new workflow. And so each of the clinics was able to kind of create their own kind of vaccine clinic based on what was most convenient for them and their clinic layout. But for instance, in my clinic, what we did is we actually shut down the clinic for 2 days, 1 to 2 days a week. And actually at our peak, we closed down for 2 days a week. And during that time, all we did was vaccinate from like 10 to 7 in the evening. And at our peak, this was, we were vaccinating up to 600 people a day. And weekly, we were vaccinating up to 1,200 people at each site. And in February, this was in February, when we started this entire vaccine campaign, our goal was to vaccinate 30,000 people in 3 months. And so we were able to reach that goal. But really what it required was, like I said, this new clinic operations where we had clinic was shut down, we had evening clinics, we also had weekend clinics, and we also were able to accommodate walk-ins. But in addition to just these new flows, we also knew that we had to go out to the community. We understood that not everybody was going to be able to come into the clinic, even with this accessible workflow. And so we developed, we
Posible.
already had.
Entonces, lo que pasó es que ya teníamos un equipo de alcance que iba a campos de labor y realmente expandimos este equipo y contratamos más staff para poder salir a la comunidad en sí.
People in schools, we had pop-up clinics where we could go to churches, community-based organizations. And so really, like I said, we went out to them, but we also had people come to us. So that was kind of the approach we took. So the other thing that we also realized is, besides we had to be accessible, we had to be convenient, but we also needed to really do outreach to promote the vaccine and also to really address the hesitancy that we were seeing. So we knew that just by having our door open was not enough. And so we really had this concerted effort to really go out and reach the community by using different platforms. We understood that we needed to be creative and use radio, and we needed to use television. And we did. We had very many public service announcements that announced the vaccine and talked about the safety of the vaccine. We also used different platforms such as Ask the Expert sessions, where we had doctors and nurses on Facebook answering questions from patients, and these sessions were both in English and Spanish. We also had some social media videos on Facebook Live. And then, like I said, we had these really focused outreach events with low-income housing, community health centers, and of course, our farm workers, who are one of our priority populations. So I want to really now talk a little bit about this best practices and successes, because I think that one of the things that we have learned and that I have learned as a clinic is that in order for us to really be able to be successful and vaccinate this many people, we really first had to have this strategic plan to support this entire operation. So like I said earlier, we really had to put on the back burner a lot of our primary care and a lot of the things that we usually do to really support this kind of work, to support the clinic workflow. So number one, I think that the leadership, it came from the top down. Everybody was really on board with this plan of vaccinating not only our clinic patients, but our community, right? We also knew that we had to be accessible and that we had to be convenient for people. Like I said earlier, many of our patients are working every day. Many patients are not able to miss work. Many patients don't have transportation. So we wanted to make sure that the vaccine sites were in the clinic where people were familiar with how to get there. People could get there by car or by their bus. It was a familiar location. But we also knew that we had to be able to be flexible and extend our office hours and allow for walk-ins. And one of the things that we did is that we expanded our vaccines not only to our patients, but to the entire community. So even if you were not a Virginia Garcia patient, but you were part of the community, you could get that vaccine for free. And I think that's another thing that we have to remember is that I've learned this with the pandemic is that even though community health centers have a big reach, there are a lot of people that do not go to community health centers or that are not engaged in healthcare. And so we have to be really creative about how we reach these people. And I think this is where allowing that flexibility of having community members be able to come in is important. But then the partnerships are really, really important because, like I said earlier, many people are not able to come into the clinic, and many people, as well known as we are in our community, many people still aren't able to get to the clinic. So really being able to use those partnerships that we had developed during COVID-19 and really kind of continue to expand those partnerships so that we could take vaccination. And I think it's important because many of our patients, like I said, they may not have a trusting relationship with their doctor, but they may have a trusting relationship with maybe a pastor or with the teacher. And so if we could take our experts, take our expertise and our infrastructure to these places, then it really did expand the number of people that we were reaching. But the other thing that I wanted to mention is that I think that even though we had great access and we were convenient and we were able to reach a lot of people through these partnerships, I think something that is key is that we are trusted members of the community. And I think that looking ahead, when we think about how we continue to reach more people, it's not just about having a place that's convenient, right? I think what I've been hearing from the community is people really want to go to a place where they are familiar, where they're seeing familiar faces, whether it's their doctor or the medical assistant or the nurse. And it really means a lot to people based on my experience when they're seeing people who look like them, who talk like them, who are actually giving the vaccine and are talking about the vaccine. And I had so many people tell me, I had the opportunity to get vaccinated at this church and it was free, but I came here because I trust you guys. I know you guys, and this is where I want to come. And so it's really the convenience, but also the trust that I think that made us so successful. With our vaccination campaign at Virginia Garcia. I do want to mention though that there are challenges when a clinic like ours, who is typically really focused on primary care, shifts over to something like vaccination, is that there is a lot of challenges and there have been some downsides. And I think one of the biggest challenges that we faced is that, we have really had reduced access to primary care as a result of this, vaccination effort that has been so successful. And what we're starting to see now is that we're starting to see a backlog in a lot of these chronic medical issues. And so what we're really finding, especially as providers, there's this internal struggle between, do we do the public health work and vaccinate, which we know is an immediate danger, or do we go back and take care of the individuals, which is what we also want to do. So there's been kind of this, I think that's probably one of the biggest challenges that we've faced and that I've faced personally as a provider with this. Also, there's staffing capacity issues. And I think this is something that we're seeing all across the country, and our clinic is also not exempt. We're seeing people that have left, people who are shifting jobs. And so what we're trying to do is we're trying to vaccinate. And in addition, we're also trying to do primary care. And we're really starting to begin to see where we're starting to see fatigue by staff and people feeling overworked. And you have to remember that we have to put that on top of people who maybe are already dealing with their own personal grief. You know, a lot of the people who work at my clinic are part of the community. Their families are a part of the community, and they work at our clinic, but their families have also been hit by COVID-19. And so, you know, there's staff fatigue plus personal grief, plus kind of this internal struggle to vaccinate, but at the same time, not forget our patients. And then the other thing that I say is still is a huge battle or a huge challenge that I think we really need to continue to keep our eye on is this battle against this misinformation and scarcity of accurate information. And although there's been so much work to try to kind of counteract that, it continues to be a problem. And I'm continuing to see it more in our younger folks, so our younger people. And what I'm finding is that many of our younger people are the ones that are really hesitant. And I think part of that has to do with some of we have not really been able to engage with them as well as with some of our older population. And I think partly it's because of our social media platforms. I think that a lot of us use Facebook and Zoom, but unfortunately, that's not really what a lot of the younger people are using. And I think we need to try to find some innovative ways to really begin to enter those platforms so that we can reach this population. Because I think that until we're able to really reach those people, we're going to continue to see this kind of hesitancy, and we're not going to be able to vaccinate as many people as we would like to. So I'm going to leave it with that for now, because I want to make sure that we have enough time to let the other panelists go, but I'm happy for any questions or comments.
Thank you so much, Dr. Galvez. Does anybody have any questions for us before we go on to the next presenter? I have a burning one. So one question, I was thinking on your last point about sort of the misinformation, particularly with younger folks. What are you seeing right now in terms of how younger parents might be feeling in terms of vaccinating their kids?
Well, I think that's a great question, because what I have been seeing is many parents, there are definitely parents who are concerned and have a lot of questions, but those concerns often seem to really kind of lay to rest when they're able to talk with the provider. But when they have teenagers, especially when the parent does not speak English and the teenager speaks English and has access to all of these resources that are in English, it kind of becomes a battle between the teenager and the parent. And many times what I'm seeing is these kids who say, well, you know, mom and dad, I know more than you because I have all these resources and they're in English and this is an expert. And so I see that a lot, actually, even in the exam room, where parents really want to get their kids vaccinated, and the kids are really kind of hesitant, and they're bringing up all these kind of like expert information to show their parents, and their parents, because they don't speak English and because maybe they're not as savvy with getting information, they almost feel like they've been defeated. And it's been a really interesting dynamic that I've seen between parents and children, especially those children who are teenagers and, like I said, have access to social media and really dominate the English language. And so back to what I said earlier, we as physicians, as healthcare providers, need to really be innovative and, you know, get into these new social media platforms, because, you know, Facebook and Zoom is not reaching those people. Those young kids.
So we have two questions. It's easier for us when everyone can see the question. So I know people are using the question and answer thing, but there's two questions that we'll combine here. And one is
going to stop share. Sorry.
Somebody wanted to know your biggest success story, but then another person came in and said the challenge really has, you know, they work with Spanish speaking and indigenous language speaking agriculture workers, and that so many families strongly do not want to be vaccinated or don't want to learn more. And so the challenge has been how to open that conversation. So do you have any successes, back to Tina's point, successes that you can share? And this will be the final question that we'll do for right now.
Sorry, and this is for indigenous?
I think she said in general, Spanish speaking indigenous and indigenous languages and agricultural workers. That's the population she's working with.
Yeah, no, I completely agree. I think there is a pocket of some indigenous workers who I myself have had conversations with, and they've been, they've been difficult because we always talk about meet the patient where they're at, but a lot of those patients oftentimes I find are a little reserved with me. And so, the first thing is trying to figure out really what is that fear. And sometimes they're not that forthcoming with that information. So that's been really tough. But I think what really works for me is really being able to have that. I think it's the one-on-one conversations that really do work. But usually that's going to happen in a clinic setting. And once again, not everybody has access to a provider. And so I completely agree that there are people who we won't reach with the social media. And I think that those one-on-one conversations are really helpful. Now, those take time. I don't think they always have to be, though, with medical providers. I think medical providers have a really important role of maybe finding other trusted messengers like pastors, like teachers, and then maybe arming them with that information about vaccines, and then maybe having them provide that information. And so I think we kind of get into this role as medical providers that we're kind of the center of the world when it comes to, teaching people about vaccines. But honestly, I think this is where we really need to be out there looking for other trusted messengers and then kind of giving them that information so that they can then reach those people. So maybe for an indigenous population, it might be, like I said, a pastor, it might be a teacher, or it might be somebody else. And so remembering that those relationships with other trusted key messengers are key.
Great. Thank you so much. We've had some really continuing great questions that are coming through. Again, if you could use the chat as opposed to the Q&A, that would be great. But what we're going to do is we're going to pause on those questions for now, and we're going to hand it over to Caroline Johnson, who will share her work from Iowa in the upper Midwest.
Hi, everybody. So like Amy was saying, my name is Caroline Johnson, and I'm the clinical director and nurse practitioner at Proteus in Iowa. And Proteus is a federally qualified health center established in 1991. We serve migrant and seasonal farm workers across Iowa, and many of our patients migrate to and from Mexico and Texas, but we see workers that migrate from various areas of Central and South America as well. In 2020, Iowa needed 4,000 H2A workers to complete the work and meet the demands of our agricultural producers. So we see a large number of H2A workers as well. Our busiest season is typically from May until August, but we're seeing that lengthen. It's becoming more common for us to see migrant workers all year long. So ultimately, we operate in a mobile clinic model, and we utilize nurse practitioners for clinical care. And NPs have full practice authority in Iowa, so we function without physician oversight. And with increased funding during COVID, we've been able to add a nurse to our team. But most of our clinical delivery is supported by unlicensed individuals that are passionate about our population. And we typically arrive at the camps or on work sites and provide primary care services to workers. We draw labs, we do PAPs, we conduct point of care testing on site, and we have discounted medications with us that we bring on site. So 94% of our patients are 200% or below the federal poverty level, and over 1,800 patients were served last year. So we've had many challenges in our state during COVID. In the spring of this year, our state legislature passed a law banning mask mandates. And as cases climbed through the month of August in Iowa, that became stressful for families who were sending their kids to school. Public COVID testing sites closed around this time also, so access to tests became challenging. Our clinic had an increase in patient calls on the basis of needing to be tested. Our governor this July blamed immigrants and crossing the border for the rise in COVID-19 cases. She stated that these individuals are coming from countries that don't have access to the vaccine and that none of them are vaccinated. And we found that to be false. And a good portion of our arriving workers had received 1 dose of the COVID vaccine prior to arrival to Iowa. And our ability to provide primary care services while trying to address these gaps became challenging. But even with these challenges, we have been successful in administering vaccine to over 1,200 workers so far this year. At one particular farm that employs 400 to 600 H2A workers, we were able to help them vaccinate 90% of their workers. Now, when I started in my current position, I had never worked in migrant health, and I found it challenging to find resources on the logistics of clinical delivery for our patient population. So this next section, I'm going to get into some of the details of our vaccine efforts for any of you who are interested. But for those of you who aren't, feel free to check your email or Instagram for the rest of my portion of the presentation. So our vaccine strategy began early. Our state primary care association facilitated conversations between community health clinic leaders, and we started sharing sample vaccine implementation processes and protocols. But because we can't be everywhere at once, we have 3 health teams and we divide the state into regions so that we're able to divide and conquer, having multiple vaccination events occurring at the same time. One of our biggest assets is that we have long-standing relationships with employers. We offered to be on site at onboardings to provide vaccine for workers as soon as they arrived. We talked to crew leaders as well, and I cannot stress enough how important this relationship is. And to best serve our workers, our staff remains flexible. We'll come early in the morning or late at night. We vaccinated on the weekends. We will come on the work site or go to the camps. We've had a few vaccine efforts within churches as well. We provided education as early as possible for workers who wanted to digest the information before we come to vaccinate. And for one employer, this meant recording a video interviewing a physician about the vaccine and addressing common concerns. And this particular employer posted this on their website that's normally used by workers for recruiting. And in the exam room, starting the conversations early. The vaccine is coming. For those who are hesitant with the vaccine, validating their fears, validating that we don't know long-term data on effects of the vaccine, but we do know that 1 in 500 people in the US have died from COVID-19, and 1 in 4 children have lost a primary caregiver to COVID. And personal stories and anecdotal accounts of the impact that COVID has had on farm workers and their families resonate with our patients and their experience. So we started vaccinating workers with Moderna because that's what was available. However, that was challenging with our limited staff, crews all over the state, and coordinating when we've returned for dose 2. So once the Johnson & Johnson vaccine was available, we pivoted to administering Johnson & Johnson. But using the J&J vaccine was challenging. We ordered the vaccine through the federal government to be delivered weekly. And initially, the vaccine ordering was put on hold while experts evaluated risk for blood clots. And then shortly after lifting that hold, we were unable to have our orders fulfilled by the federal government due to the amount of vaccine in the field. So we were directed to reach out to other health centers to transfer doses instead. So this was logistically challenging. Other vaccine challenges, groups of workers arrive sometimes at unpredictable times, depending on weather or what is going on in the fields. So we asked for notice to be able to order or locate vaccine that was needed, but some groups struggled to do this. And some workers had symptoms following vaccine administration, and this made crew leaders hesitant to vaccinate remaining workers before work was done. And so I'll just give you some details on how we did it. Let me preface this by saying that our process is in no way perfect, but this is the real life mobile clinic version that we came up with after plenty of trial and error. So the people that we needed a vaccine coordinator and a vaccine reporter. There's a lot of reporting that has to be done regarding utilization of vaccine. Ordering and inventory, especially with 3 regions, took a lot of coordination. We have Spanish speaking staff, and you'll see they had a variety of roles at our vaccine efforts, and vaccine administrators. Because of our organization's current structure, we used registered nurses and nurse practitioners to administer vaccine. And for certain large vaccination efforts, we'd have one of our nursing staff to draw up the vaccine. So you can see it took a whole team of people to be able to pull this off. Our plan went kind of like this. So first, patients arrive. If possible, we would try to stagger those in groups every 15 minutes. We'd have groups of 10 patients every 15 minutes, ideally, but that wasn't always possible. But it helps with patient flow when you can do it. And for those that arrive in one big group, the vaccine information sheet is reviewed with the group presentation style. We go over common side effects and suggested medication to alleviate those symptoms. That was discussed at this time as well. Then these individuals, they register as a patient. This is done by bilingual staff, and then they're given the COVID vaccine patient questionnaire. Registration staff are trained on how to answer common questions regarding the questionnaire, but anything complicated or any questions that they are unsure of, we have nursing staff to navigate those conversations. And then the patient brings their completed questionnaire to the administrator. The administrator reviews it, asks what questions there are about the vaccine, signs the bottom, notes which side the vaccine was administered on, and then the administrator keeps that documentation. The patient is then given a timer, sent to the waiting area, 15 minutes for most, but 30 minutes for anyone with previous anaphylaxis to vaccine or medication. And this waiting area is monitored by clinical staff. Once the timer goes off, the patient brings it to the checkout person who completes the vaccine card. And then once all workers are vaccinated, the administering providers count the number of questionnaires. We compare this with the number of empty vials and remaining doses, and those numbers should match. Then we compare with administrative staff the number of patients who registered. And once all of these numbers match, then the lead nurse will email a vaccine report with the number of vaccines given and wasted at this particular event. Then within 72 hours of administration, we would have staff enter the vaccine into our EMR and the state vaccine registry. Some of our earlier efforts, we tried to do this in real time, and it lengthened the time of our vaccine effort considerably. So tools that we needed. So we started the summer, we had just some regular camping coolers that were not adequate in maintaining stable temperatures as we're traveling to the camps and to the fields. So we invested in Yeti coolers that worked well. We used portable battery operated temp monitors in these coolers. And there are more expensive options for both items out there, but these worked well for us. We brought kitchen timers, all of the vaccine supplies, needles, syringes, alcohol, Band-Aids, gauze, gloves, sharps containers, cards, and emergency equipment as well, because you just never know. And then we would draw up vaccine in large numbers for these larger testing events. It was most efficient for us to do it that way, but so we wouldn't waste vaccine. We'd base this on the number of individuals that had arrived to be vaccinated already. And then as we worked through the group, the person drawing up the vaccine would be in close contact with the registration staff about how many people were left to be registered. So then we'd slow down on how much vaccine we were drawing up. We draw the vaccine up with one needle and put a new needle on the syringe prior to giving the vaccine to someone. Though some will say the step is unnecessary, dull needles hurt, and this step prevents unnecessary pain. And then once the vaccine is drawn up, it has to be labeled. The syringe was labeled with pre-printed stickers with the lot number and the date. Time is added to these by hand. And then for efforts where we were using multiple lot numbers, we would use a color coding system with the stickers. So using the strategy, we were able to vaccinate hundreds of workers in just a few hours. And I'm so thankful that we have the tools to lessen the impact of this virus on farm worker families. And I'm incredibly proud of what our team accomplished this year. So thank you for inviting me to share the lessons we learned, and I'm happy to answer any questions.
Yeah, Carolyn, I'm gonna go to a few questions that are coming through in the question and answer piece. So it would be great if you all could use the chat so everyone can see the questions. But one really interesting question that MCN's been dealing with, and I'm sure it has come up for you. What are you doing if this is being requested? I'm making an assumption about requests for duplicate cards, because folks are sometimes not always working in the name that they're working under a different name than their actual name.
So we commonly have those requests, and our clinic is used to workers having aliases. So we will complete the card just so we aren't jeopardizing their ability to work.
That's the same as MCN's position, where our priority is public health first, get folks vaccinated, keep them employed. And one question that I think that that has come up as well is, are you using any kind of incentives to motivate community members to get vaccinated, like gift cards or a drawing for a prize? Has that been needed?
We did not really need that much this summer. I feel like most of the crews were very willing to be vaccinated, but the workers who are here year round, I feel like we're using that more in our brick and mortar clinics. And we do plan to incentivize families that choose to get boosters this fall as well. And we've had some donations to do that. I know DoorDash has donated a bunch of gift cards, and we've been handing those out as well. So we try to incentivize as much as we can with whatever we have.
Great. And then just to finish us off, Caroline, what has been like one of your most successful strategies that you've employed to convince a family to get vaccinated?
I think a really important thing for providers to remember when they're in the exam room is sometimes you have to close your computer and give patients your full attention. And we're so pressed for time that it's tempting to document while you are seeing the patient. But I've found in vaccine conversations, it goes a lot better. I'm more effective if I do not have a computer between us, and I validate fears, validate concerns. I hear what they're saying, and more than anything, I want to promote their autonomy and ability to choose. So I think those things in the exam room, those moments can be really powerful and have been the most successful.
Great. Well, thank you so much. We're going to stop questions for a moment and hand it over to Nadia Julian who is going to talk to us about working on the Delmarva Peninsula with our Haitian community here. Welcome, Nadia.
Thank you for having me. I say, well, I thank everyone for choosing to participate in that webinar. Thank you for the warm welcome and the invitation. My name is Nadia Julian. I am a nurse practitioner with Tabitha Medical Care that is located in Lowell, Delaware. We are about, I would say, 20 minutes from Salisbury and like 7 minutes to Seaford. It's a little rural area, very small. So I'll give you a little bit about the clinic. We are a primary care clinic. It's very young. We open in October 2019, right a couple more months before COVID hit. And we serve the population that we serve. It's varies. But the majority of our patient, about 60% of our population are Haitian Creole, and 20% are Hispanic, and the rest are Caucasian and African American. So it very varies. Our really work on COVID. You can go to the next slide. So in Delaware, we have the rate of vaccination. At least 80% receive one dose, 18 and up, and our percentage fully vaccinated is about 64. Next slide, please. And in Maryland, the population that receive at least one dose is about 65%. And about 50% are fully vaccinated in Maryland. So our job has been pretty much on both states. You can go on the next slides. So we been active on the health equity. That's my passion. Since I am a daughter of a farm worker. My father, he moved from Florida to Salisbury. So that's where he headed, working on the farm, and he worked in the poultry plant for 30 years after he retired. So when I'm doing education with the migrant and immigrant communities, I feel like that I'm giving back to my roots. So with this vaccine equity, like we already know, the Black and Brown community are the most effective, the one that are mostly affected by the virus, and the vaccination rate is lower. So like you can see, about 38% Black has been fully vaccinated in Delaware. But since we not differentiate between, Haitian Creole and Black, so we fit into that category. Next slide, please. So how we've been doing vaccination and also COVID-19 distribution and education, it's very unique because our population is unique. So we do a lot in the clinic. So we started our vaccination campaign. It was last April. We started with our first vaccination clinic in the clinic. We about our patient population. So we have a total of about 1,500 patients over the last 2 years. So we started with all inside clinics. So our patient population, the Haitian we focus on, they are very, very reluctant about the vaccine. So we had to do a lot of education, a lot of 101, and we had to meet that population where they at. So as October 19, so we vaccinated over 450 patients in the clinic that are fully vaccinated. Our oldest patient was 91. A youngest patient was 13, and we also vaccinate pregnant women that was about 5 months pregnant. Next slide, please. So our approach to education, before I go to the challenges that we have, so we in the exam room, like Caroline was saying, so we take the time to really address the patient concern, what's keeping them from not being vaccinated. So we said there's whatever the reason it is, feel free, you can share it with us. And if there is things that we can clarify, we are more than welcome to do it. So we do vaccine at least two days a week at the clinic. On Friday, which is our lead day, we open from 8:30 to 7 p.m. The reason being because our population, they work and they don't like to miss work, and I don't want them to have an occurrence too at work. So with the late hours, we'll be able to meet those patient needs. And also on Saturdays, like every Saturdays from 9 to 2, we also have a clinic and clinic hours, a vaccination clinic. So to give that opportunity for those patients that work and they cannot take the day off, they have the Saturday, they can come and get the vaccines. Education is the key. At the beginning of the campaign, we do a lot of presentation using the social media or WhatsApp to send like videos about the science behind the vaccines, address the side effect, the myth, and the conception, and all those education that were done in their native language, Haitian Creole. That can also give them the opportunity to have question and have somebody that speak the language do the education for them. So, but during the our vaccination campaign, we have some challenges. Like you already know, like I already told you, I am a fairly young clinic. We are a primary care clinic. We are focused on health prevention, primary care, chronic care, and acute illness management, and also preventive care of medicine, and as well as education. So for that young clinic, so we don't have a lot of resources. I am the only provider at the clinic, and I am the main person that's do the education, that also do the vaccination clinic. So, but with the help of the state, that we were able to increase our staff. So we had an administrative assistant, doing our vaccination clinic. We are able to get the flow of the vaccination clinic. So when the patient come, so most our patient, even most of them don't speak the language, and even the Hispanic patient that we serve, they don't speak the language. We had to hire as well a community health worker that speaks Hispanic, and also one that speaks Haitian Creole part-time to help us in that journey. So when doing our vaccination clinic campaign or clinic, so we have those staffs are there to help the patient register and provide the information about the vaccines. And some of them, even though they speak, that we have the form in their language, and sometimes, most of the time, 50% of the time, they required help to fill out the form. So we help them, from the beginning of the process to the end. And so when they are ready, so we get them into the vaccination room. So we administer the vaccine, and we have a post-observation area that's monitored either by, we have a lot of nurses, like Haitians, and also we have a lot of volunteers that come from Delaware Health and social services. Most of the time when we reach out to them for volunteer, they send us nurses doing our vaccination clinics and in-site and also off-site clinics. So we are fortunate for that. And when we come, so we have our administrative assistant. She's the one that responsible for our reporting and also the race, and also to keep the log of the people that are vaccinated, so we can regenerate the report of the patient that are vaccinated, and also enter all those information on Delvax. But like the challenges that we face, especially with Black communities, because I also do education not only on Haitian community, and also in African American community, and also in Hispanic communities. I go to the most of my education or faith basis. So I go to the churches and I meet the person. I talked about the vaccine. I give them information, and then I answer the questions, and then at the end, because that's very important for them, especially the Haitian community. And I found that too, also in the Hispanic community, in the faith-based, they like when you go, you don't just come and vaccinate, but you come to assess and to be part of the service. So, but with the challenge that I find, especially with the clinic and also with off-site community clinic that we do with community events, it's transportation. Transportation is a big thing, especially with the Hispanic and the Haitian population. So with that barrier, so we have some of my staff help and volunteer. Sometimes it's free. It's free. It's a volunteer service that they give me when we have clinic. So they go and get the patient for me. When we register those patients, we also have, they can make an appointment for the vaccines, because we have an ad in the local TV. They can register for the vaccine. We do vaccine and also testing. They can register or they can walk in. So during those days that we have vaccines. So for those who don't have transportation, so we have a list of people that need transportation. We can go pick them up to be vaccinated. And also one of the things that I found is the myth and the misconception about the vaccine, especially in the faith-based community, because I got that question a lot, where it is the mark of the beast. As a Christian myself, I always find myself try to explain to them what the vaccine is, not to confuse it with the mark of the beast. And also the chip that's inside the vaccine, especially because we have a lot of undercommitted residents. They are afraid that the chips that's in the vaccine, the government might know wherever they are, so they can come get them and deported them. So that's some of the myth and the challenges that on the education that we have to really address. And as well, it's also the infertility part, especially for the younger population that don't have any kids. So this is, and also erectile dysfunction. My younger male patient always bring that concern. So it's there for them to clarify those myths. And also the mistrust about, the vaccine, the arm. So the long-term effect of the vaccines, what's going to happen to me 2 to 3 years after being vaccinated. So that's when we have to go to, it's a working process. So we cannot determine as 2 years the effect of the vaccine, because it's still on the work, and the research are still being done. But we can assure you the efficacy and the safety of the vaccines in the clinical trial were very stunning, and the research, the results were very effective, and for the vaccines to do what it was supposed to do, as far as develop immunity and to have antibodies to protect you against the vaccines. And one of the big things that I have done a lot, especially with the Haitian community, culture is a big difference, because I have that, because I do a lot of education in the poultry plants, where I go and do COVID vaccine education for the Haitian population, for the Haitian associates only. So the incentives is a no-no with the Haitian population. So that's where I came into. I go to Purdue, to Manair, and also Amic Farm, and Island Food, and explain it's not working with the Haitian community. So if you the reason why the rate are so low into the poultry plant, because with the Haitian community, they said, why they have to pay me to take something that's good for me? If it's good for me, I don't need money to do it. So it's like it's different with every population, and I have to explain them. It is not paying you. It's like this is it, in the American culture, this is something that's well acceptable. But for us in the Haitian population, it is not well received when the incentive comes. Next slide, please. So I mean, like our big success are, it's building the trust, because the trust is very important. So every time that I do like a community event, and then I go to the churches and invite them. I go to the stores and invite them. When they see like a familiar face and somebody, because I have them before I started to go to the poultry plant. So some of my people, my patients, they would come. They said, "I'm only gonna take the vaccine." That's the one of the reason why Tabitha become a site, because it said, "I'm only gonna take the vaccine if you offer the vaccine. If you give it at the clinic and you tell me it's okay, I'm gonna do it." So when the building the trust with the provider, like every medical provider, you build a trust with the community that you serve. You build a trust with that patient. So that's why, or you always have to be honest. At the beginning, I spend a lot of time to teach them about the side effect of the vaccine. When they have those side effects, I tell them what to expect when they have those symptoms, so they don't say that the vaccine make them sick, because that's how the immune system is supposed to respond, to the vaccine. It's help building the trust when you have those familiar really in the ethnic group that goes and do the education and do the vaccine clinics, and also the informative events. So from the beginning of the campaign, we did a lot with the state of Delaware. So we did like videos about, the science of the vaccines, the myth, and we were able to do them, some of them in Creole, some of them we speak both languages, and to help release the fear of the community and be there to answer the questions. So when I go to a church, or I go to like a grocery stores, it's a opportunity for me to educate. When I see somebody without a mask around COVID, when I see somebody I talk to them about the vaccine. Have you vaccinated yet? So, and it's always like a conversation. They said, "Oh my God, if I see Nadia, I know she's gonna talk about either COVID or vaccine." I am passionate because I know what COVID is. I was really sick with COVID, 2 weeks in the hospital, and I lost my mother through COVID. So whenever I'm doing an education, it goes from my heart. It goes from a personal level. So I go to the churches on Sundays. That's what I do. I try to at least do 2 Sundays at my church because I have responsibility. But the other Sundays, I'm on somebody's else. I'm another church in the community. I go to the Hispanic church, some in Salisbury, in Delaware, in Maryland. So wherever they ask me, and now after that, we can do vaccines. Those are very good. And one of the real talk that I have now, it's called Real Talk, or Mwelil in Creole, on Parler. So it's like real talk, let's talk about the vaccine. Come with your free question. That's how I do it when I go to the poultry plants with the Haitian Creole associate. I let them come with their questions, and I address the questions. And if I have to give a little bit of the science of the vaccines and go deeper with the conversation, I'll do that. So those are the techniques that I use to get the community educated so that they can make an well-informed decision. It's still a lot of work a lot of work that we have to do, but I think that we can do it. Next slide, please.
Nadia, I'm gonna interrupt you and thank you for an amazing, amazing discussion, and also being from the community where you work. Also, thank you for your efforts, because you are just such an amazing source of education and advocacy, as well as providing them. What I would love to do, I also wanted to point out just one thing that Nadia, well, several things that Nadia talked about, but I think it's really important for all of us to remember some of the barriers that were discussed here, and that a lot of times we think that vaccines are so accessible, yet transportation and some of these things that make it inaccessible are still problematic. What I would like to do right now is put your questions in the chat. In a few minutes, we're going to open up the floor to all of our panelists. And what I would like to do is have Sarita join us and just go through a few resources, and then we'll come back to our panelists and have a few questions that have come in. Thank you so much.
Thank you so much, Amy.
Thank you.
I'm just going to share my screen really quickly. Okay. Thank you so much for having me today. So my name is Sarita, and I am the communications strategist with the National Resource Center for Refugees, Immigrants, and Migrants, or NRC-RIM. And so I'm just going to start out by giving you a quick background about NRC-RIM, and then I'll go over some practical multilingual resources that you can use in your communities. So NRC-RIM is funded by the CDC and housed at the University of Minnesota, and we exist to support health departments and community organizations working with refugee, immigrant, and migrant communities that have been disproportionately affected by COVID-19. And we do that by strengthening partnerships between health departments and communities, and supporting organizations that work with refugees, immigrants, and migrants. Now, because we work with health departments and community-based organizations, we're sort of one step removed from the community, and we rely on our partners like the Migrant Clinicians Network to keep us informed from both the perspective of the worker as well as clinicians. And MCN is a core partner of NRC-RIM and has been instrumental in the development and distribution of our health communications materials. So I'm going to talk to you today about our collection of multilingual resources. We work with partners like MCN and the International Rescue Committee, who are doing work on the ground to find out what questions and concerns they're hearing and what kind of materials we should make and the best way to distribute these materials. We then design materials with a professional designer and get it translated, often in up to 45 languages. And we have a very rigorous translation process. Our translations are completed by a professional translator, proofread by a second translator, reviewed by a linguist, and we also then send it to a community reviewer who may or may not have formal language training to make sure that our materials are both culturally and linguistically appropriate. The Get Vaccinated campaign is our first campaign that's based on feedback that we've gotten that indicates that people from many different backgrounds connect with the theme of protecting their communities. And the goal here is to create awareness of COVID-19 vaccines and the impact that they have on a collective group. And so this campaign includes posters and social media assets, which are currently available in more than 40 languages, and we're adding more all the time. And so these campaigns are customizable. So if you want to remove our logo, change the URL, use a more culturally affirming photo, we have templates available for you to do just that. Here's a sample of our social media assets associated with this campaign. And so we got some feedback saying that everyone liked the dark blue branding that you see there on the left. So we created a second version of these materials with a little bit different look. And so you can also customize this Band-Aid campaign with photo options that celebrate people with different skin tones, body shapes, and with different identifying markers like freckles, tattoos, and scars. This is something we just launched, messaging about COVID-19 decisions being private. We know that in some communities, people are interested in getting the vaccine, but they're reluctant to do so because of social or political pressure. And we want to make sure these people know that there are options for getting their healthcare needs met while honoring cultural expectations. The Get the Facts campaign is based on CDC guidance, offering facts about COVID-19 vaccines in a simple and memorable way that counters common misconceptions. These facts address cost, ingredients, side effects, eligibility, and more. And these are also available in more than 40 languages. And just like Get Vaccinated, they also come with drag and drop templates for you to add your own logo, swap out the photo, and do some minor editing. So this campaign includes a social media series, fact sheets, and even audio and video PSAs for people who don't read in the language that they speak or who may rely on a more oral tradition. We release new fact sheets from time to time that address emerging issues like vaccines for children, or breakthrough infections, wearing a mask after you're vaccinated, things like that. Here's a list of the languages we currently use for our campaign materials. We include more commonly translated languages like Spanish and Arabic, as well as Haitian Creole and indigenous Central American languages like Popti and Mixteco. Vaccination is our last campaign, and this was created using a community-led hyper-local communication strategy that was developed by and for members of narrowly defined local communities. In the examples you see here, MCN worked closely with leaders in Latino and Haitian communities in Maryland to co-create customized vaccines campaigns. Now, we know that unique communities need unique approaches to COVID-19 vaccine confidence that honor their priorities, the values, and their expertise of community leaders. So these campaigns are not being translated into 40 languages because the messages are not universal. They're hyper-local and customized to each community's unique needs. In MCN, the Migrant Clinicians Network had a significant impact on this campaign by customizing the materials for their stakeholders and distributing the tools on their website, social media, and in local communities. We also created something called Make Space, which is a tool for public health professionals and community-based organizations to make their own customized vaccine campaigns in partnership with local communities. So with our guide, anyone can learn how to plan, create, and validate their campaign using the same community engagement process that we use for Vaccination Is. Now, the Get Vaccinated and Get the Facts campaigns are effective if you need to broadcast messaging that's universal at a large scale. But for a more targeted campaign, it's important to partner with the communities themselves to learn what will work best. And with our tools, you can easily conduct this mass communications campaign for your broader community, as well as develop targeted messages for those who are hardest to reach. And we believe that both these approaches are important for any vaccine campaign strategy. I have our contact information here. I also wanted to just show you a quick demo of some of our materials and how easy they are to use. So you can see our website here. This is our Get Vaccinated campaign. Are you able to see? Yeah. This is our Get Vaccinated campaign. So you can see we have posters, we have a social media series, and we have this confidential messaging as well. This is our Get the Facts campaign. In this, I will show you can see we have social media, we have fact sheets, and you can either click on one of these languages and download it and just repost it, or you can click on the customizable versions. So I'll just open up the Spanish one here. Now this opens up sort of a preview. You click Use Template. Just take a minute for it to load. Okay, so here, if you don't want to use our logo, you can just drag it off the screen. You don't need to use it. We link to the CDC, but if you want to link to your clinic website, you could just type here and update that URL. And if you don't like this photo, you can just delete it. And we have other photo options that are pre-sized and ready to go. So I'm just gonna click this one here, or maybe I'll use this one. I'm gonna do Control-C to copy, Control-V to paste, and I just place it right here. It's already the perfect size. Just right click or Control click if you're on a Mac, click send to back. And now you have your own customized fact sheet that you can print out and use with your community. So that's what I have to share. I'm going to stop sharing my screen and I will pause for questions.
Thank you. Thank you so much for sharing that. I really encourage everyone to go to that NRC RIM website. There's just a wealth of material, and you're going to get a copy of all the slides that we were used in this presentation today, so you can see some of the links. You'll also get a recording if you need a review on how to do the materials. In the slides that Sarita shared, there's just even more materials on the MCN piece when we sort of, you know, took off with that Vaccination Is campaign and have been working with folks across the country with it. So there's lots of great resources and images as well on that one. So everyone's saying what great information. So Martha, if you could put all of our panelists back up. We had a few pressing or, you know, really good questions. First, there was like a big shout out to all of our panelists for the work that they are doing, and I just want to share that shout out with everyone. The other question that came up that I am wondering, first, this one's for Nadia, since we sort of ended with you quickly, but someone was wondering if you could just go a little bit deeper into that fertility question and help us understand how you talk to your patients who are concerned about fertility regarding the vaccine.
Yeah, so for those who concerned about the vaccine, I just told them that, I mean, in the clinical trial, there was a patient that was in the clinical trial that got the vaccine and got pregnant afterwards. And also I know people that's got the vaccine from the beginning and got pregnant. So, but there is no, even though, I mean, there is no data like on the pregnancy aspect of it, but we know that there is people that really take the vaccines and they got pregnant after they take the vaccine. Yeah.
Great. Does anyone, Caroline or Dr. Galvez, would you like to respond to that at all?
I guess my comment is very much like what Nadia said. I tell people, you know, I still practice OB, so I tell people, you know, I understand the concerns that you have, but listen, I have colleagues who are doctors and nurses who got this vaccine in December and January, and now they're pregnant and have had babies and they're doing just fine. Or I also tell them about my patients who are pregnant right now who were vaccinated because they were the essential workers who were vaccinated initially. So I try to stay away from the arguing about the science that they're reading about the infertility, because I think that it kind of just takes us down a rabbit hole that's not very productive. And what I try to do is shift away from that to really like, well, this is my experience and this is what I am seeing as a provider who takes care of women that are pregnant. They're going on to have healthy babies, and I give them examples of somebody who was just born in April or May and June, and suddenly they're, you know, we're talking really positively about it. And I can also tell them about examples of women who are pregnant and have had COVID and have been really sick. And so again, going back to those experiences and making it really personal, talking about people in their community who've been pregnant, have been impacted and had a better outcome because they were vaccinated, is really where I like to go.
Great. And Caroline, maybe you could respond to this question. Folks are wondering, and this is what I've been wondering at MCN the whole time, so curious about what you and the other frontline providers think about this. how are you handling sort of like the constant information coming in? Now we can mix and match boosters, and so how have you been able to sort of keep that, what they call corrective science conversation, going with your patients as all these new directives come out?
I think it's important to remind everyone that this is a novel virus, and we don't have any long-term data or huge studies on COVID. We are starting to see data come out now that we've been going through this for so long, but I think it's important to remember and important to remind our patients that we are learning as we go. And even at the very beginning, we really had to rely on our knowledge of science and fundamentals of pathophysiology to get us through, to make recommendations in the beginning, because we just didn't know so much. So I think it's just important to be transparent, and science is an evolving thing. And as far as being able to booster with other things, even at the beginning of the vaccination efforts, they say, I remember reading on the CDC website, there was a section about, if you get Moderna, there isn't another Moderna available, then you can get Pfizer. If Pfizer isn't available, then you can get whatever is available. So I feel like from the beginning in the vaccination effort, we're just trying to get people immunity. And as long as we can do that safely, I think that, safety is the bottom line there. But yeah, so just reminding people that we are living a giant experiment right now. And I will be so excited to look back on all of this data, look at all of these retrospective studies, looking at this time.
Thank you. Dr. Galvez or Nadia, do you have any thoughts on how you all been responding to this the changing directives and the changing information with your patients?
I agree with what Carolyn said, being very honest and just saying we our things are evolving and our priority is always safety. And so if things are changing, it's because a week ago or two weeks ago, we were not sure if things were maybe safe. And so it's really out of caution is what I tell people is as things are changing, it's really out of this caution to make sure that we are putting out a vaccine that is going to be safe. And I think people do appreciate that honesty, is just knowing that this kind of showing that humility that we really are along on this ride as well. And we're trying to put their best health and interest. And for that reason, sometimes maybe we're a little hesitant, but once we have better science, and then we'll go forward with those recommendations.
Great. And Nadia, do you want to close us out here with any thoughts on this?
Well, I mean, safety is priority. So safety is number one priority. So continue as healthcare provider to stay and update about the vaccine, so we can provide the most updated information to our patient, and be honest, be humble with whatever the research shows, and be there for our patient throughout the journey. I think that's the most important thing that we have to do as medical providers.
Great. Well, I want to close this out and just say thank you to Sarita, Carolyn, Dr. Galvez, everyone for their great insight and their participation. We really love to hear from you. We take our evaluations so seriously. We would love it if you would fill out our evaluation. If you need continuing education, you have to fill it out. And if you want to just give us feedback, we welcome your input. So for those who need the credits, the evaluation is a must. For others, it's still a must in that we want to hear from you so that we can always improve our work together. Again, Sarita offered some really great resources that we hope you all use. NRC RIM has just a wealth of materials in so many language. MCN has been excited to be a partner with NRC RIM. So I encourage you all to look at the NRC RIM website, and then also taking that Vaccination Is campaign to another level. Check out some of the work that MCN's done. I think you'll find it all super, super useful. And we'd love to hear from you on our evaluation. And we want to just give a huge round of virtual applause to our amazing panelists. Thank you so much for not only being with us this afternoon, but for being on the front lines. And you all have done just this amazing work for so many months, and we wouldn't be here without you. So thank you so much.